Hello, good morning, good afternoon, and good evening to those joining from different time zones. It's my great pleasure to welcome you to today's webinar. I'm Marc-Andre Cornier. I'm a professor of medicine, director of the Division of Endocrinology at the Medical University of South Carolina, and I'm the president of the Obesity Society for 2025. It's truly an exciting time for the field of obesity medicine, and we're thrilled to have you here for what promises to be a truly insightful discussion. Before we dive in, though, let's do a few housekeeping details before we get into the discussions. So there will be a question and answer, a Q&A feature. There'll be time for Q&A on the agenda. So please submit your questions directly in the question box at the top right of your screen. After the lectures, there will be a case discussion, and then we will have the panel come to discuss that case together. After that, we will have the formal Q&A period. We have a fantastic set of faculty joining us today, and it's a great pleasure to welcome all of them. We are joined by Dr. Jamy D, who's an immediate past president for the Obesity Society. He's a professor at Wake Forest University. We have Dr. Ania Jastreboff, who's associate professor of medicine at Yale University. Dr. Lee Kaplan, professor and chief of obesity medicine at Dartmouth. Dr. Robert Kushner, professor of medicine and medical education at Northwestern University, Feinberg School of Medicine. And finally, we have Dr. Donna Ryan, professor emerita at the Pennington Biomedical Research Center. Here is the agenda. I will start things off, the kickoff about obesity as a serious chronic disease, followed by discussion by Dr. Robert Kushner on the definition, diagnosis, and recommendations, reviewing the new Lancet Commission. We'll be hearing about Semaglutide, more than weight loss by Dr. Ryan, Tirzepatide for the treatment of obesity by Dr. Jastreboff, and finally, the future of obesity pharmacotherapy by Dr. Kaplan. And Dr. Ard will do the case presentation, and he will then moderate a case discussion with the rest of the faculty, and we'll follow that up with a Q&A, and then we will close for the day. We're very excited to start this morning or afternoon or evening for you, and hope you enjoy this webinar. To set the stage, we're going to start by talking about obesity as a serious chronic disease, and with the idea of treating obesity first. Not the last thing on our problem list for our patients, but the first thing, the thing that really leads to all the other complications. Here are my disclosures. So the American Medical Association defines a disease as an impairment of normal functioning of some aspect of the body. This is associated with characteristic signs or symptoms, and it leads to harm and morbidity. So the question, does obesity meet this definition? Well, yes, obesity is due to appetite dysregulation, abnormal energy balance, and endocrine dysfunction. So this is an impairment of the normal functioning of the body. This is associated with characteristic signs of increased body fat and symptoms associated with increased body fat, such as joint pain, altered metabolism, sleep apnea, and many others. And this then leads to harm and morbidity, as we see obesity leading to type 2 diabetes, cardiovascular disease, cancer, reproductive disorders, hypertension, steatotic liver disease, dyslipidemia, and many others. So it starts with energy dysregulation, both on the appetite regulation side and then energy expenditure, in the right environment leading to excessive calorie intake. That positive energy balance, those calories need to be stored, and they get stored as adiposity or fat, leading to excess adiposity, which is often measured as a high BMI. So we have biological signals impacting energy balance, so adipose tissue signals like leptin, intestinal signals like ghrelin, GLP-1, PYY, pancreatic signals as well. Then there are many other factors that impact energy balance. Medications that patients might be on, hedonic inputs, our genetics are key, and how we interact with the environment. So our energy expenditure based on physical activity, basal metabolism, adaptive thermogenesis, and our energy intake due to behaviors, food availability, hunger, satiety signals, hormonal, neuronal appetite signaling. So it's pretty clear that obesity results from an inappropriate energy intake cues to hormones and signals. And this is driven by the genetic predisposition to an obesogenic environment. Excess adiposity leads to many complications throughout the body. You name an organ system, it is impacted by excess adiposity. We don't have time to go through all of these, but we'll be touching on a number of these throughout this sessions. Obesity also dramatically reduces economic activity, reduced health-related, increased absenteeism due to health-related reasons, disability costs, fewer adults in the workplace, and increased healthcare costs. We are changing the narrative here. Obesity is not just a risk factor for comorbidities. It is, in fact, the root cause for many of these serious complications. Organs throughout the body are impacted by obesity, including metabolic health, mechanical dysregulation, as well as mental health disease, many cancers, and so many others. But the selection of obesity treatment should not just be based on a calculation that takes only height and weight consideration, the BMI. Treatment selection should be a shared decision and should be taken into consideration other factors such as complications, race and ethnic differences, personal preferences, and psychosocial factors. The good news is weight loss is associated with significant improvements in obesity-related complications. And the more weight is lost, the more benefit we see. So 0 to 5% weight loss is very clinically meaningful. It improves hypertension and hyperglycemia. 5% to 10% might lead to reductions in type 2 diabetes and fatty liver disease and other metabolic disorders. 10 to 15%, we might start seeing improvements in cardiovascular disease, in sleep apnea, and other serious complications. And finally, with more than 15%, we see type 2 diabetes remission, cardiovascular mortality reductions, and heart failure improvements. More is better. We have many different interventions that are possible for weight loss, from lifestyle all the way to surgery. And we can see on this figure the average amounts of weight loss we see with these different type of interventions, anywhere from 3 to 7% with lifestyle interventions to 3 to 20% with obesity medications, and upwards of 25 to 35% weight loss with different surgical procedures. The exciting times are with these new medical therapies. In the US, we now have 3 new medications in the last couple of years, one of which is only for rare monogenic forms of obesity. But we have Tirzepatide and Semaglutide, both now approved in the United States, that have led to significant amounts of weight loss, more than 15% on a regular basis, as seen in these trials. But not only are these new treatments associated with significant weight loss, they're associated with significant benefits in other health outcomes. So with Semaglutide, we see the benefit in cardiovascular disease, as well as other conditions such as liver disease, osteoarthritis. With Tirzepatide, we see not only benefits on weight loss and prediabetes, liver disease, but on obstructive sleep apnea, with significant benefits in patients who have sleep apnea, whether or not they're treated with CPAP. This has led to the FDA approving Tirzepatide for the treatment of moderate to severe sleep apnea. And we have many new emerging pharmacotherapies that are being investigated. We'll have a whole session on this later in this webinar, but it's very, very exciting to see so many different potential therapies coming, hopefully, to us in our clinics very soon. Well, let's shift gears a little bit and turn to the diagnosis and definitions of obesity. And we're going to ask our next panel member, Dr. Robert Kushner, who's professor of medicine and medical education at Northwestern University. We'll tackle this topic of new definition, diagnosis, recommendations from the Lancet Commission. Dr. Kushner.
Hello, I'm Dr. Robert Kushner. I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine, and I'm going to present on the new definition and diagnosis recommendations for obesity from the Lancet Commission. I want to start with a concept that we all know about, we've talked about at least for the past decade, and that is that obesity is a chronic disease. What I'm showing you here are multiple definitions from around the world, starting with the World Obesity Federation, all the way to the top left, all the way to the Obesity Medicine Association on the bottom right. And I've highlighted in yellow some key concepts in which they all share. And that is that obesity is defined by excess body fat. And when it comes to a disease, it's progressive and it's chronic, and it may be a gateway to other medical conditions. I want to explore this a little bit more with you, though, these two concepts. First, that it's a disease. Second, that it's identified by excess body fat. We know from a recent publication that obesity is associated with over 200 complications and comorbidities. Many of them are shown here in these two diagrams of a male and female. But towards the right, I want to emphasize something we're going to come back to in more detail when we talk about the Lancet Commission, and that is, what is a disease and how do we define it? And to remind you all, a disease is a disorder or abnormal condition affecting the body or mind characterized by specific signs and symptoms. That's a very important concept. And furthermore, a disease impacts an individual's normal physiological or psychological functioning. These are basic concepts that we often fail to focus on when we think about just complications or comorbidities. We do know now that obesity is pathological by itself. It isn't just a gateway to other medical problems, but obesity itself, by dysfunctional adipose tissue, can cause signs and symptoms and complications. And it's demonstrated in this one slide. Towards the left, you see a healthy cardiometabolic profile where when one takes in extra energy, more than they're burning on a daily basis, it's the body fat that stores and holds that energy, either through hyperplasia or hypertrophy. And as long as it stores it safely within adipose tissue, you don't get release of adipokines and cytokines and spill over into other organs, which we call ectopic fat deposition. They're spared and they function normally. Now, that's in contrast to the right, in which we have dysfunctional adipose tissue, where it is no longer able to store the energy that we take in on a daily, weekly, monthly, or yearly basis. And then the free fatty acids and extra energy begins to spill over into other organs, which we call ectopic fat deposition, as well as inflammation begins, in which you get release of adipokines and cytokines. So we have direct information, at least for over the decade or so, that obesity can be pathological by itself. The other concept of obesity is that it's excess body fat. And there's been a challenge to directly measure body fat in the clinical environment. These are 4 different techniques that can be used. Some of them are more practical, such as multiple frequency BIA or perhaps DEXA, although that has radiation. The others are air displacement, and then digital anthropometry towards the right. So we can actually measure body fat, but it's very, very difficult for a clinician, either because of cost, inconvenience, radiation, or it's not quite ready for prime time, which would be digital anthropometry, which is towards the right. Because body fat is so difficult to measure, we have relied on a concept called body mass index, originally Quintilla index, later termed body mass index by Ansel Keys. And we've used this at least from 1985 to 1990s and all the way into the 2000s to identify obesity, which is a surrogate measurement of extra body fat. Towards the right, you see the cut points that have been applied by the World Health Organization, at least to European white populations, where we have cut points of underweight, healthy weight, overweight, all the way to severe obesity. There's problems, however, with BMI. One is heterogeneity of relative body shape and composition that exists across race and ethnic groups, sexes, genders, and age span. And it's essential to consider when applying BMI as a measure of adiposity. In other words, it will change depending upon who you are as an individual. Another problem is that BMI defines body size with no regard to an individual's health or body composition. It's very difficult to say someone has a disease without ever having gotten a medical examination or seen on an individual basis, which is the last bullet point. Now, we also know that beyond BMI, there are other anthropometric measurements that starts to look at the where body fat is deposited, or body fat deposition, which also will indicate not only excess body fat, but also in a staging process, increased risk. And one of the very first additional anthropometric measurements to look at was actually waist-hip ratio. This is data from 1984, looking at a cohort of women in the TOPS Club from 1969. And what you see is that regardless of the BMI, either no obesity, moderate obesity, or severe obesity, the higher the waist-hip ratio, the greater risk of percentage of developing diabetes. So not only does waist-to-hip ratio or waist circumference measure body fat, it also has an assessment regarding risk. And that's further shown in a later study of 650,000 white individuals, where we look at BMI across the x-axis, and then we look at subgroups within each BMI class by waist circumference in this case, and you see an increased hazard ratio of developing all-cause mortality. So it's not just BMI, it's also where the weight is located. That also tells us about body fat. So our current practice guidelines for assessing patients with obesity recommend that we measure height and weight and calculate BMI annually. We measure waist circumference for those with a BMI of 35 kilograms per meter squared or less, and assess for weight-related complications. So this is background information before I now go into what the Lancet Commission was all about. So Lancet Commission was 58 commissioners or experts from around the world who used the consensus to arrive at recommendations. And the aim was to reframe the definition of clinical obesity as a condition in which the risks to health associated with excess adiposity be objectively documented by specific signs and symptoms reflecting biological alterations of tissues and organs, which is consistent with existing illness. And we met monthly, believe it or not, from June 2022 to December 2024. So to restate what the purpose is that we call obesity a disease, but frankly, what are the signs and symptoms of the disease of obesity? And secondly, how can we really identify who has obesity beyond BMI because of all of its limitations? So we try to develop a new framework for the diagnosis of illness due to obesity. The Commission pragmatically distinguishes clinical obesity from preclinical obesity. These are two new terms, which I'll go into in a minute, based on the presence or absence, respectively, of objective clinical manifestations, that's signs or symptoms, of altered organ function or impairment of an individual's ability to conduct daily activities. So, in short, the Commission did two major moves forward. The first is, how do we confirm excess adiposity? That's a definition of obesity by itself. And then secondly, how do we diagnose clinical from preclinical obesity based on objective measures of illness at the individual level? And I want to point out one important point at this right here, is that the commission did not look at staging of illness or using BMI to identify increased risk. What we wanted to do is to identify excess adiposity by itself, and then look at how do we define clinical obesity or preclinical obesity. So let me start with the very first step forward, and that's how do we define excess body fat? And that is, how do we confirm an individual with an elevated BMI or not an elevated BMI who actually have excess body fat? And we came up with 4 different criteria that can be used. The first is you add at least one measurement of body size. That could be waist circumference, waist-hip ratio, or waist-to-height ratio in addition to BMI. So at a minimum, you have at least 2 anthropometric measurements. The second can be 2 anthropometric measurements, waist circumference, waist-hip ratio, or waist-height ratio, regardless of BMI. So that could be an individual with a BMI, let's say, of 22 or 23, but you have 2 other measurements that confirm excess body fat. That would be obesity. The third can be directly measure body fat, such as with bioimpedance. There are many clinics, at least in the United States and maybe other first world countries, that are doing body fat composition measurements, but pragmatically, we can't really do that around the world. And the fourth is we identified individuals where the BMI is so high that it wouldn't be necessary to do another measurement. An example would be a BMI of 40 or greater. So we define obesity as a condition characterized by excess adiposity with or without abnormal distribution or function of adipose tissue. That's very importantly. So once you have obesity, that is excess body fat, now do you have the disease of obesity? So we tackle that separately. We said that the disease of obesity, which we said clinical obesity, requires confirmation of obesity status. We already did that. That's excess body fat, plus evidence of one or more of the following. First is reduced organ or tissue function, specifically due to obesity, with signs and or symptoms of impaired organ dysfunction, such as respiratory, cardiac, renal, musculoskeletal, and so forth. Or trouble with mobility and day-to-day activities such as bathing, eating, continence, etc., due to impaired impact of excess body fat. So one or the both would then give you a diagnosis that body fat is impacting the health of the body. That's called clinical obesity. However, you can have obesity, which is excess body fat, without any signs or symptoms or impaired health. So no signs or symptoms of reduced organ and tissue function, and have no impairment of daily activity. However, very important to identify what we write on the right is that it's a people with preclinical obesity can have a variable but generally increased health risk, including risk of developing clinical obesity or other obesity-related diseases, such as cardiovascular disease or cancer. This is a very important concept. We specifically use the term preclinical obesity because those individuals we know from longitudinal studies that have already been conducted have a higher risk of going on to developing complications or comorbidities given enough time. So they may be at increased risk of having clinical obesity, therefore you want to keep an eye on them. But not all of them will. So it's called preclinical obesity, but it's not self-determined that they will all develop problems. Now, the commission went on to give examples of what would be signs or symptoms or blood studies that would suggest that the body fat is harming an organ system. And we came up with 18 different criteria divided by different organ systems, and you could read them here. So examples would be excessive shortness of breath. It could be recurrent or chronic urinary incontinence, chronic severe knee or hip pain, or a variety of cardiovascular system disorders such as heart failure, preserved ejection fraction, atrial fibrillation, elevated blood pressure. An example of a blood test would be elevated blood sugar, a low HDL cholesterol, and an elevated triglyceride. Now, the last thing we did is we talked about management recommendations. So for clinical obesity, we recommended these individuals should receive comprehensive evidence-based care that is timely and initiated with the aim of fully regain or remission or improvement of the function which has been reduced by excess body fat. And we would define successful treatment should be assessed by improvement or resolution of clinical manifestations rather than measures of weight loss alone. Very important concept. With preclinical obesity, the approach may be different. It may just focus on risk reduction based on individual specific level of risk, and these individuals may only need monitoring over time and health counseling. However, if an individual is at increased risk of having clinical obesity, such as a high family history of type 2 diabetes or heart disease or different types of cancer that may be related to obesity or other impairments, treatment certainly can be initiated. So lastly, I want to leave you with this image. The commission is the beginning of a long, windy road. We anticipate a lot of dialogue, a lot of suggestions, modifications of our recommendations, additions of signs and symptoms, and so forth. So look at it as the first step forward to have the conversation to move beyond BMI. Thank you very much.
Hello, I'm Dr. Donna Ryan, and I'm going to be talking to you about semaglutide, and I've titled this More Than Weight Loss. So these are my disclosures, and you need to be aware of my relationships with lots of companies trying to make these new medications for obesity and disease modification. So semaglutide is not the first GLP-1 receptor agonist. We've had them around really since 2005. So they were initially developed for the treatment of diabetes, and the very first one to be developed for weight management was in 2014, liraglutide. This medicine never really took off. It produced modest weight loss, but it never really garnered all of the attention that we're seeing recently. That happened with semaglutide in 2021 when that was released for weight management, for obesity treatment. And the amount of weight loss was attractive to both patients and prescribers. But really, another important event in sort of driving all of the interest in these GLP-1 receptor agonist medications was the SELECT trial results, which came out in 2023 and demonstrated a reduction in MACE in individuals with overweight and obesity but without diabetes. And that really has driven a lot of interest in developing medications in this class and of nutrient-stimulated hormone approaches. So since then, there's been even more excitement generated about the potential of these medications to modify all of the chronic diseases that are filling our offices. So we're seeing efficacy in things like chronic kidney disease, in heart failure, HFpEF, heart failure with preserved ejection fraction, MASH, obstructive sleep apnea, and even some interesting evidence emerging around Parkinson's disease and COVID. So let's start at the beginning, and let's start with that weight loss efficacy of semaglutide 2.4 milligrams, which was studied in the STEP 1 trial in adults with obesity without diabetes. And in this study, the average weight loss was 14.9%. And that was really a groundbreaking amount of weight loss. But that average weight loss is not really what I think attracted all of the attention. So what I'm showing you here is the cumulative distribution plot from that of the percentage weight loss from that STEP 1 study. And the semaglutide group is in the dark gray, and the placebo group is in the light gray. And I've drawn 5% weight loss in the green line and 10% weight loss in the orange line. And everything to the left of that is greater than 5% weight loss or greater than 10% weight loss. And as you can see in this on-treatment analysis, the patients on semaglutide who lost 5% or more represent 92.4% of the population, and greater than 10% weight loss, almost 3/4 of the population. So what this really demonstrates is that almost all patients who are being treated with semaglutide 2.4 milligrams are going to achieve clinically significant weight loss. So we believe those 5 and 10% cut points are where we really begin to see health improvements associated with weight loss. So that is hugely important. The ability to provide efficacy for most of the patients that we're prescribing for. But look, this semaglutide molecule is interesting for other reasons than just weight loss. And if you look at native GLP-1, it has pleiotropic effects, which I'm illustrating here. And yeah, it has effects in the pancreas to have that incretin effect to lower blood glucose, but it also has effects in the brain to promote appetite reduction and weight loss. But look, native GLP-1 reduces blood pressure. It has effects in the kidney to promote natriuresis and diuresis. In animals, there's evidence of cardioprotection. It reduces coagulation in platelets. It delays gastric emptying and so reduces postprandial lipids. And importantly, native GLP-1 has anti-inflammatory properties, both in fat and in other tissues. So semaglutide, having 94% homology with native GLP-1, was a very good molecule to study for the prevention of cardiovascular events in people who are at very high risk. You know, before the SELECT trial, we had never demonstrated that we could really have an effect on a hard endpoint, on a disease-modifying endpoint. And so the SELECT study is a huge study, 17,000 individuals, all of whom had established cardiovascular disease. They had had a heart attack, a stroke, or had symptomatic peripheral artery disease. And they were randomized to receive either placebo or semaglutide 2.4 milligrams on the background of the very best in cardiovascular risk reduction we could provide. Not weight loss, but cardiovascular risk reduction. So control of lipids, blood pressure, inflammation, and such. And so here I'm showing you the time to first event, MACE, major adverse cardiovascular event, was a 3-point MACE consisting of cardiovascular death, non-fatal MI, and non-fatal stroke. Here's the Kaplan-Meier curves for placebo in green and semaglutide in purple, and you can see the event rate is lower for the semaglutide group, and it begins to separate almost immediately. So there's no delay in the event rate reduction. Overall, this is a 20% reduction in cardiovascular events. Truly a groundbreaking moment in obesity research, because it's the first time that we demonstrate that we can actually have an effect on a disease-modifying effect. And fortunately, this 3-point MACE, all three components contributed to the reduction in the cardiovascular events, and there were no losers in terms of our subgroup analysis. Everybody seemed to benefit regardless of age, sex, BMI status, and other subgroup analyses. So it makes us think, what kind of medicine is this semaglutide? Yes, it has an indication for diabetes along with many other GLP-1 receptor agonists, and it has an indication for obesity along with Tirzepatide and liraglutide. But this is the first time we really got an indication in the FDA label for reduction of cardiovascular events in high-risk individuals with obesity without diabetes. This is a groundbreaking moment in obesity research. But look, that's not all. So one thing that the SELECT did is it's given us a lot of insight into other effects of this semaglutide. And so there was, in the SELECT study, there was a heart failure endpoint. About 25% of individuals in SELECT actually had heart failure, either HFpEF or HFrEF, when they entered the study. And heart failure is a very adverse predictor of MACE events. So the individuals who had the heart failure had the highest MACE rates, and that was reduced by those on semaglutide. And indeed, we had a composite heart failure endpoint, and that composite heart failure endpoint was also demonstrated to be reduced in the SELECT trial with treatment with semaglutide. Now, semaglutide had also been studied in individuals with obesity and without obesity in 2-step HFpEF trials of heart failure with preserved ejection fraction. And that, again, demonstrated that there was a reduction in there was improvement in the Kansas City cardiomyopathy questionnaire. So improvements in how patients were feeling. And then there was also improvements in the 6-minute walk test. So demonstrated they were able to walk further distances, and therefore there was improvement in function. I need to point out that semaglutide's cousin, Tirzepatide, has also demonstrated these things in their HFpEF studies. In addition, they have also demonstrated a reduction in hospitalization. Okay, so another interesting thing that we saw in SELECT was in our terms of chronic kidney disease outcome. We had a kidney endpoint, and it was reduced by 22% in those patients who were randomized to the semaglutide arm. And this has been also shown in the studies of semaglutide flow, and that's the study of chronic kidney disease progression in people with type 2 diabetes. And those flow studies did demonstrate that there was a reduction, a 24% reduction in patients who had established chronic kidney disease in terms of progression of that. And that primary outcome was kidney failure, a greater than 50% reduction in estimated GFR, or death due to kidney disease or cardiovascular disease. So that was reduced by 24% with the semaglutide group. And most interesting in those flow studies was that there was this benefit occurred whether or not the patients were on SGLT2 inhibitors. So, in diabetes, we promote the use of SGLT2 inhibitors in individuals to preserve renal function. And on top of that, we got additional benefit with semaglutide in patients with diabetes. So important. And another important disease-modifying property of semaglutide. Let me show you something very interesting from the SELECT trial, and that's the mortality data. So if you look at the deaths, there were 833 total deaths. Well, 58% of them were from cardiovascular diseases, but 42% were from non-cardiovascular diseases. And if you look at the reasons that people died except for cardiovascular disease, it was primarily due to infection or malignancy. There was no difference in the semaglutide arm versus placebo arm in terms of malignancy deaths. But look at this. There was a reduction in deaths due to infection in the semaglutide treated patients compared to placebo. We did further analyses. I'm not going to show you this data in the interest of time, but what it showed was that there was a reduction in COVID deaths associated with semaglutide treatment. So the semaglutide arm had fewer COVID deaths compared to the placebo arm. A very, very interesting observation from the SELECT trial. So another very good thing about semaglutide being the first is that we have a lot of data around semaglutide. Not only the data that was presented to the FDA as part of their approval, their phase 3 studies, that's part of their approval for chronic weight management, but this SELECT trial really does add to that data around safety. So importantly, it adds not only a large group number of people, 17,604 individuals in the study, but it also provides data from individuals from around the world, from men and women. 75% of the individuals in SELECT were men, whereas in our weight loss studies, they're predominantly women. And, so men and women of all ages. And so just to summarize the safety of semaglutide, I think we had no surprises. We have no surprises thus far. It seems to be in line with all of the class effects of the GLP-1 receptor agonist, and so that's a very good thing. We did observe in the SELECT trial that there was a numerical increase in individuals who were over age 75 and in women over age 60, a numerical increase in fractures of the hip and pelvis. But overall in that SELECT study, there was no imbalance in fracture rates of placebo versus semaglutide patients. So overall, a very rich data set to support what we know about the safety of the GLP-1 receptor agonist medications. So what we're seeing here is that these medications are about a lot more than weight loss, and their effects are being mediated not just through weight loss, but through the effects of these medications. So we have indications for diabetes, obesity, cardiovascular disease. Tirzepatide has a new indication for obstructive sleep apnea. And we're seeing emerging evidence for the efficacy of these drugs in chronic kidney disease, in MASH, and in heart failure with preserved ejection fraction, and in other conditions. So I think it's more than weight loss. Semaglutide is more than weight loss. It's about disease modification also. So to conclude, here are the messages I want you to walk away with. Number one, semaglutide is the first medication to show clinically significant weight loss for most patients. That's a groundbreaking thing. It's also the first to show disease-modifying attributes. That secondary prevention of cardiovascular disease in persons with obesity without diabetes is another groundbreaking study. And third, it's continuing to show evidence of modification of other obesity-associated chronic diseases, and it's been joined in this by the other drugs that are in that nutrient-stimulated hormone class. And what appears to be happening is that these positive attributes of the GLP-1 receptor agonist target are being added to by other targets of GIP, of glucagon, of amylin, but mostly in combination with that GLP-1, because we do have demonstration of really excellent disease modification attributes of that molecule. So, in addition, the final message is that semaglutide studies provide a rich data set of evidence of safety and efficacy in a broad population across many men and women of all ages and from many countries. So, thank you so much for your attention. I enjoyed talking to you about this.
Hello, my name is Dr. Ania Jastreboff. I'm an associate professor at Yale, trained in both pediatric and adult endocrinology. I'm an obesity medicine physician scientist directing our Yale Obesity Research Center, Why Wait? And today I have the pleasure of speaking to you about Tirzepatide for obesity treatment. You just heard a beautiful talk from Dr. Ryan about semaglutide, and now let's talk about Tirzepatide. These are my disclosures, all related to the exciting field of obesity medicine. So, as we know, unfortunately, by 2030, nearly half of Americans will have obesity. And we have to think about obesity, the disease in and of itself, and how it affects all of our patients. We also have to think about how obesity impacts the potential development of so many other obesity-related diseases. And that, as we treat obesity, we can also potentially prevent, mitigate, or treat many of these other diseases, potentially over 200. And so when we think about all of these agents, the ones that are already FDA approved that you're hearing about today, semaglutide and tirzepatide, as well as the host of all these agents in development, yes, we often do focus on, well, the weight reduction. But it's also really important to know that not only is it important to focus on weight reduction, and with these agents, more than 15, 20, potentially even 25 or 30%, but it's important to also think about beyond just the weight reduction. Yes, that's important. But when we're treating obesity to improve overall health outcomes. And so let's talk about tirzepatide. This is the first GIP GLP-1 receptor agonist. It is a single molecule administered once weekly subcutaneously. Now, this molecule is a receptor agonist for both GIP and GLP-1. So we have to think about the unique pleiotropic effects that this molecule may have that GLP-1 receptor agonists may not have. And that's because these hormones and their receptors, they act in different tissues and organs in our body, as is demonstrated by this slide. Now, if we go to the data to look at what we know about tirzepatide, in the SURMOUNT-1 trial, we demonstrated that individuals receiving the highest dose of tirzepatide lost up to, on average, 22.5% of their total body weight at just 72 weeks. We know that this translated to an average weight reduction of about 52 pounds, and that 40% nearly 40% of participants lost at least a quarter of their body weight. So that means that someone starting the trial weighing 200 pounds lost down to 150 pounds. Now, not only was the weight reduction important, but also we saw improvements in several cardiometabolic measures. Now, the participants in this trial, none of them had diabetes. They had obesity plus minus prediabetes. You can see here, though, that their A1C improved, as did their blood pressure and lipid panel. Now, the question is, did these improvements in cardiometabolic measures translate to, for example, heart benefit? Well, the SURMOUNT-MMO trial is ongoing. It's looking at individuals with obesity without type 2 diabetes, and importantly, it's looking at both secondary as well as primary cardiovascular event prevention. The SUMMIT trial already concluded. This was a trial looking at participants with obesity with heart failure with preserved ejection fraction. And uniquely in this trial, what it demonstrated was an improvement, a significant reduction in heart failure outcomes. And this included urgent heart failure visits as well as heart failure hospitalization. So this was unique to this trial and very important. SURMOUNT-OSA looked at individuals with obesity and obstructive sleep apnea and demonstrated significant reductions in AHI. And this trial led to the FDA approval of Tirzepatide for obstructive sleep apnea. And this is the first medication that is FDA approved for that indication. Tirzepatide, of course, is also FDA approved for obesity treatment as well as type 2 diabetes. So as we can see, Tirzepatide treats obesity as well as these obesity-related diseases. And so the next question that we had was, can Tirzepatide prevent some of these diseases? And in this case, we looked at the prevention of type 2 diabetes, looking again at the SURMOUNT-1 trial, this time looking at the 3-year outcomes in those individuals who had prediabetes at baseline when they enrolled in the trial. And so the question that we asked is, can treatment with Tirzepatide prevent progression to type 2 diabetes? And the answer was a resounding yes, with a 94% risk reduction in progression to type 2 diabetes in those individuals who were treated with Tirzepatide. In fact, nearly 99% of participants treated with Tirzepatide remained diabetes free throughout the course of the trial, and the number needed to treat was 9. So that means that we needed to treat 9 individuals over the course of 3 years to prevent just 1 case of diabetes. So very impressive results. So with all medications, there are side effects, and this class of medications, of course, has side effects as well. And we know that the most common are gastrointestinal. They are transient and occur mainly during dose escalation. Now, these 2 pieces of information are very important because it means that as providers, we really have the ability and the tools to mitigate and prevent many of these side effects. And the most important way that we can do that is to start with the lowest dose always and to titrate up slowly. So these are the titration schemas for Semaglutide and Tirzepatide, and the green box just reminds you that there's no requirement to increase the dose once per month. We increase the dose as the patient tolerates or needs an increase in dose. So remember to always start low and go slow when using these medications. Our patients can also do certain things to help mitigate or prevent these side effects, such as eating smaller amounts, stopping to eat when they're full, or noting which foods exacerbate their symptoms. Now, the next important question is, if these medications are continued, will the weight and health benefits be maintained? So let's come back to the SURMOUNT-1 3-year outcomes and look at weight first. So as you can see here, over the course of 3 years, substantial weight reduction was achieved and maintained. You can see here with the highest dose up to on average 22.9% at 3 years. What about hemoglobin A1C? Can we maintain that? And you can see here the baseline A1C of 5.8, reducing down to on average 5.1, and you can see substantial A1C reduction was achieved and maintained with Tirzepatide. And what about blood pressure? So I'm showing you here systolic blood pressure. You can see the same effect with diastolic blood pressure. So improvements in both systolic and diastolic blood pressure achieved and maintained throughout the course of the 3 years of this trial. And the next question is, if the medication is discontinued, what happens then? Well, you will not be surprised as to what happens with all of these outcomes. So off drug, we looked at 17 weeks, so about 4 months off of the medication. And what we see is that when the medication is discontinued, we should not be surprised. It cannot work if a person doesn't take it. And so the average weight regain was about 7% over that period of time. And what about hemoglobin A1C? So what we can see, not surprisingly, is during the time off drug, the hemoglobin A1C started to increase back up towards baseline. And what about blood pressure? Same thing, started to increase back up towards baseline during that off-drug period. So we know that continued treatment is needed to maintain the beneficial effects, whether those beneficial effects are weight reduction, improvement in glycemia, or in blood pressure. And the same thing can be said for lipids. So the bottom line is, for a medication to work, the patient needs to continue taking the medication for any chronic disease, whether that's obesity, diabetes, hypertension, or any other disease. And so with that, I come back to our patient and the need to treat that patient holistically. Most of our patients have obesity. They may have obesity-related diseases. But imagine if we could treat this one disease, if we could treat obesity, and in the process, treat all of these other diseases as well, always keeping the patient at the focus and at the center, and making sure that we're helping them to lead the healthiest lives possible. And with that, I thank you so much for your attention. If you want to hear more patient stories, come check out this Oprah podcast. If you want to hear more about the research that we're doing, you can check us out on our Why Wait website. And thank you for caring for our patients and for treating obesity. Thanks so much.
Hi, my name is Lee Kaplan, and I'm going to be talking about the future of obesity pharmacotherapy. Now, as you've already heard, we've made tremendous strides in improving pharmacotherapy, and this slide shows that. While bariatric and metabolic surgery has been pretty stable and very effective in treating obesity, as you can see by the red to green transition of that bar on this slide, it's become much safer. Intensive lifestyle therapy, lower down in the yellow bar here, has been around for a long time. It's pretty stable in its efficacy, but much easier to administer. But the real changes have been over the last 10 or 15 years in the efficacy of anti-obesity medications. For the first 40 of the last 60 years, anti-obesity medications were no more effective than lifestyle alone. Now, they combined the two and you could get more of an effect. But over the last 15 years, as shown here in generation 2 or in the green background, you see with the introduction of combination therapies and the first GLP-1 receptor agonist, liraglutide, we see that these dark blue bars are significantly higher than what you can get with just lifestyle alone. Over the last 4 years, what we've got is the development and introduction of semaglutide and tirzepatide, highly effective GLP-1 receptor agonists. And you can see here that they are substantially more effective than the medications that came before and are even pushing toward the efficacy of bariatric and metabolic surgery. Now, the new medications that are being developed are even more effective on average, and there are many of them, more than 100 in development right now. And some of those are likely to equal or exceed the efficacy of metabolic and bariatric surgery. But each of them has different characteristics, and that's what I'm going to talk about. Now, as you can see here, that as good as these medications are, here's semaglutide, there's a broad distribution of how much weight somebody will lose. The average is 15 to 16% in patients without diabetes, but look at this distribution. Some people will lose more than 20% of their weight, and 1 in 9 will lose more than 30% of their weight, or more than the average for metabolic and bariatric surgery. At the other extreme, though, 10 to 13% of patients in the phase 3 clinical trials without diabetes lost less than 5% of their weight or even gained weight, as shown here. And if they had diabetes, as is shown in the step 2 trial, 31% lost less than 5% of their initial body weight. And this is also true of tirzepatide, where that number is just over 20%. Now, obesity isn't only a problem of excess body weight, excess body fat, because obesity is associated with metabolic stress, which then exacerbates the obesity, leading to ectopic fat accumulation, inflammation, cell injury, and fibrosis in all of the organs shown here. And many of the metabolic complications of obesity derive from these changes within these different organs. Changes in the pancreas leading to diabetes, changes in the vascular system leading to atherosclerosis. And these different complications of obesity have different characteristics. They're more or less likely, they're more or less associated with the amount of the severity of the obesity. And it shows that there are probably different mechanisms by which these different complications occur, even though they all relate to dysmetabolism. When we think about newer medications, we think often about multi-agonists. And you've heard about dual agonists like Tirzepatide is a GIP, GLP-1 dual receptor dual agonist. But there are two basic types. There's the peptide fusion type, where you just basically take two ligands of different receptors, two different mechanisms by binding to two different receptors, and you just fuse them into a single molecule. And we'll talk about those in a minute, but the one that I want to talk about right now is the peptide chimera, because that's what Tirzepatide is, and that's what some of the next generation of medications is likely to be. And that's because you can take different amino acids from these different peptides, shown here in blue on the left and those in orange on the right. And in this situation, you can make a chimeric combined peptide, a single peptide that can bind to both receptors. And one example, and that can occur because glucagon, GLP-1, and GIP turn out to share a lot of similarities in their structure. And the similar or identical amino acids of these three peptides are shown here in yellow. So because the peptides, each one of these peptides is closely related in the key areas to the other ones, you can create a molecule that has as many as all three of these different agonists. And so if you have these three different peptides and you make a combination with some of the amino acids from one and some from the second, some from the third, you get a medication like retatrutide, which is the first triple agonist, GLP-1, GIP, and glucagon, that can bind to and activate all three receptors. And these different activities, even though they are from related peptides, are very different physiologically in all of the different organs, as indicated on this table here. And just as an example, you can see in the liver that glucagon has effects that neither of the other two have, but the effects in each organ are different for each of these. So when you combine them, you get the effects of multiple combinations, and that can be positive, negative, but in the case of the peptides that are being developed right now, they are very largely positive across the body. Now, coming back to the peptide fusion molecules, one example of that is amycretin, which is a fusion of a GLP-1 receptor agonist with an amylin receptor agonist, both of which cause weight loss, but have different characteristics. And it is hoped that for people who don't respond to GLP-1 receptor agonists adequately or don't tolerate them, then perhaps by the addition of the amylin fusion with an amylin receptor agonist could be beneficial. Another example of that is Maritide, which is a fusion of an antibody to GIP, which makes it a GIP antagonist, the opposite of the activity of Tirzepatide on GIP, combined with or fused to two copies of a GLP-1 receptor agonist shown here. Now, when we think about all the different possibilities of other mechanisms besides GLP-1, GIP, glucagon, and amylin, you can see there's a long list here. And there are medications being studied in various stages of commercial and clinical development against all of these mechanisms, alone or in combination with each other. One of those is bimagrumab, which is being developed for treating obesity, and also has the characteristics, because it interferes with the inhibitory effects of myostatin on muscle. It blocks the inhibitory effects of myostatin. it leads to elevated muscle mass in the setting of weight loss from other mechanisms. And so the hope is that the combination of bimagrumab and something else might preserve muscle. So far, we don't have enough data to know whether that's actually going to be realized in terms of functional muscle, but it is one of the examples of how the benefits of combining one activity with another. So what do we need in new medications? We need improved average efficacy for sure. We need complementary mechanism of action so that we can help people who don't respond or don't tolerate the medications that are already available. We need improved ease of use for patients, including greater tolerability, simpler escalation or no escalation requirements, oral administration, longer acting drugs, and a lower price. And we need improved ease of use for prescribers, particularly primary care prescribers who don't have time to work as intensively with each patient for the dose escalation variability from patient to patient. And then finally, as we talked about, preservation of muscle and bone mass is a critical component, particularly for people who are older or who have sarcopenia. So with that in mind, you can see that even though we've made great progress over the last 20 years in developing these drugs and over the last 5 years in using these drugs, there's great opportunity for improving further and a lot of exciting activity to develop drugs that will complement and extend what we already have. Thank you very much.
Now we will hear a case presentation by Dr. Ard, professor at Wake Forest University and our immediate past Obesity Society president. Dr. Ard.
Thank you, Mark. It's great to be here and have a chance to be a part of this program to present a case on obesity management. And what we'll do is just jump right in. I'm Jamy D, I'm a professor here at Wake Forest University School of Medicine. And let's talk about our patient for today. Here are my disclosures. So we're going to meet Claire. Claire is a 48-year-old female who has a BMI of 36, class 2 obesity. And she comes into the office and she says, I've got a few things that I'm interested in talking about. She's perimenopausal. She's having irregular menstrual cycles, hot flashes, sleep disturbance. You take a social history. She works full-time in a sedentary job office or office job, and she lives with a spouse and 2 teenage children. She's interested in talking about her weight. She says, she's had obesity for a long time, a lot of attempts at different lifestyle changes, diet and exercise. Usually they're not successful in the long term. Maybe she can get some momentum for a few weeks at a time, but nothing really has been able to lead to long-term success. She has a history of depression and anxiety that's been intermittently treated, but not on any consistent therapy. And she's got concerns about menopause, perimenopause, and weight gain and mood changes. All of the things that sort of go along with perimenopause seem to be making some of her, sort of baseline issues worse. So in the past, when you talk about treatment that she's had before, she said, well, she tried phentermine in her early 20s, had some success with that, but stopped after a couple of months due to concerns about heart health. And this was right around the time that people were talking about phentermine, fenfluramine, and there was concern that, phentermine might be causing some heart issues. And she never really had a significant workup, but she had those concerns. When you ask about support system, Claire's family expresses skepticism about medical treatments for obesity or things like surgery. They sort of feel like, well, you should just really be able to do it on your own. They're all lean, active, and everyone engages in a healthy lifestyle at home. But Claire is the one person who still has to deal with obesity. So when you ask what would she like to accomplish, she identifies two main things: sustainable weight loss and improved energy. Those are the things that she would like to have. And she's open to treatment options, even though family may not be as supportive. She's open to evidence-based treatment options, including medication. So when you do your assessment, you look at her BMI, as I said before, it's 36. Blood pressure is a little bit elevated at 134/82, and she has an elevated waist circumference at 38 inches. 38 inches. Her mental health, she has a PHQ-9 score of 9 and a GAD-7 score for anxiety of 10. So those are both in the sort of moderate range. Labs show slightly elevated total cholesterol and LDL cholesterol. She has a hemoglobin A1C of 6%, which puts her in the prediabetes range. Liver and TSH, liver enzymes and TSH are normal. As documented before, she has some sleep disturbance. She's not sleeping through the night, definitely having some hot flashes that cause awakening. She is experiencing some mood swings, crying more at things that generally should not lead to her feeling emotional. And she's noticing that a combination of these things, not sleeping well, mood swings, is having an impact on her level of energy and fatigue, and that's also, you know, impacting motivation. So she'd like to be more active, but with all that's going on, it's hard for her to really sort of find the energy to do so. So thanks. Look forward to talking with everybody once we get back into the discussion.
All right. Hope everyone is able to hear me okay. Can I get a thumbs up? I had to get my headphones on here. Um, so I've got my all-star starting five here. If I had to pick my all-star lineup for the for an obesity showcase, this would be the team. So I've got a bunch of questions that I know will help our audience further, you know, sort of think about this case. And I'm going to go with Dr. Kushner first. Um, Dr. Kushner, in this particular case, we have a female patient who is interested in obesity treatment, and we've got a diagnosis of obesity based on her BMI and past history. But are there other diagnostics that you would do in this particular case to help you further evaluate her situation? And if you would do those diagnostics, can you help us think about how that would inform your treatment decision thinking? Because then I'm going to go to Dr. Jastreboff to talk about what her considerations and treatments might be.
Yeah, thanks, Jamie. First of all, I have to tell you, this is one of the most challenging patients we see. You know, it's like an outside force has taken over their body, and
Yeah.
they're just so distraught. So it begins with understanding, listening, and acknowledging. I just want to start with that. She certainly has symptoms of perimenopausal symptoms. As you said, hot flashes and sleep disturbance. I probably want to further explore if she has sleep apnea. That may be
Mm,
part of what's going on there. Certainly, her mood, anxiety, depression really jump out at me. I probably want to understand that a little bit more. I'm not sure I would do more testing than the scales that you already did, but I'm thinking of treatment really down the road. And hemoglobin A1C elevated at 6% really jumps out at me.
gotcha. So, Dr. Jastreboff, you've got now an assessment that includes a sleep study to rule out sleep apnea that Dr. Kushner's ordered, and you got some additional evaluation, maybe a referral to you know, behavioral health professional, mental health professional for the anxiety and mood disorder issues. When you think about talking about treatment with this patient, give us a sense of how you approach that and how you frame that. And let's assume for the for this discussion that she has access to all treatment options available. She's got excellent coverage.
Yeah, I mean, it's a really great question. And it sounds like she's open to various forms of treatment. That's really a really good place to start. And I just want to highlight what Bob said also in terms of her mood and everything, just taking the patient in from the start in terms of where are they, what are their goals, what are they looking for, validating their struggle, their frustration, and making sure that we're always coming back to the fact that this is biology and this is not something that the patient chose. It is not their fault, and we are here to help them, and we're going to keep on going until we find solutions. So for her, she has several things going on, and Bob highlighted several of them. I would definitely, if she's open to medications, and again, we're going to frame it all within the context of also doing lifestyle interventions for her. If she's open to medications, I would choose ones that could potentially also target those weight-related diseases. So, for example, she has an A1C of 6. We certainly don't want her prediabetes to progress to diabetes. We know that prediabetes already predisposes individuals to microvascular disease, macrovascular disease. So we really want to take that head on when you're choosing therapies. And then also finding out what's going on in terms of sleep apnea, which if she did not have coverage, that may potentially help get coverage for certain medications. Well, the one that's FDA approved for obstructive sleep apnea, which is Tirzepatide. If she has available to her everything, I would choose something that, again, with discussion with her, that could target some of these things altogether. So if she was open to a medication that was injectable, then I would speak with her about Tirzepatide and Semaglutide. If she had obstructive sleep apnea, it might push me over towards that, since that there is an indication there. If she wanted to start a little bit more slowly, then something like metformin, again, to target that insulin resistance as we're slowly working towards helping her in terms of her weight. So that's where I would start. But most importantly, I would see where she is and what she was open to, and then target as many things as I can with the focus on obesity treatment.
Got it. So your objective then is to try to say, okay, what's going to give me the broadest impact in a single therapy
Yeah,
and lead to as many, addressing as many of the challenges that she's dealing with, the health issues that she's dealing with.
exactly.
So, Dr. Kaplan, I'm coming to you. I'm going to switch that scenario now and say she doesn't have insurance coverage for any obesity medication. And let's say she's looking at paying out of pocket for any treatment that you might recommend in that situation. So, in your perspective, I'm sure you've seen lots and lots of patients in that scenario because a lot of our patients may not have access. So, in your perspective, how do you tend to counsel patients about treatment options? What are the things that you prefer if patients are having difficulty accessing some of the newest treatments? You're on mute.
This is the more common scenario, unfortunately, not the less common one, where patients don't have access to as much of the coverage as we would like them to. I guess I would start back at the beginning and see if there's something about her history that would tell us what might be in her lifestyle or in her environment that could be promoting her weight gain or promoting obesity. Because if we could find something that is dominant, a particular type of food or diet, stress, particularly chronic stress, sleep deprivation, or something like that, even maybe a medication, then we can go to that cause as the first therapy, because that doesn't cost any money. That's just a matter of changing lifestyle, but doing it in a very targeted way.
Mm,
I also would follow up on what Dr. Jastreboff said, which is to focus on the possibility of metformin, which is not indicated for treating prediabetes, but is used very commonly and can cause weight loss. We also know for this patient that she responded some years ago to phentermine without
mm,
particular side effects. And at the time, phentermine was only considered as a very short-term intervention for obesity. It was confused by having a similar name to fenfluramine, which really had the heart effects, the greater heart effects. And I think that I would come back to that as a very inexpensive medication. Obviously, we have to be concerned as she's getting older about cardiac side effects of her obesity, and so therefore we want to make sure that was done carefully. But once again, so you've got metformin and phentermine as starting points, and then you can start to think about the less expensive drugs that aren't as effective as perhaps the newer ones, but the combination of phentermine and topiramate, the combination of naltrexone and bupropion, and those are other things that would be possible before you get to the very expensive drugs. And then, of course, as time goes on, even the very expensive drugs are going to become much less expensive. So we have a great deal of opportunity for her for the future, even through the things I've just described, but also even with the newer medications.
Gotcha. Thank you for reviewing that. I think that's really helpful advice because, as you said, a lot of our patients are in that category of not having coverage or having inconsistent opportunity to be able to access some of the newest treatments, but there's certainly value in some of our early generation medications. So, Dr. Cornier, I'm going to come to you now. Dr. Jastreboff mentioned that this patient would also be engaging in some type of lifestyle intervention if she's also on obesity medication as a pharmacotherapy, or lifestyle as an adjunct to pharmacotherapy. So from your perspective, what's the key role here in terms of lifestyle intervention? What does that play if she's going to be on one of the highly effective medications, and we're anticipating, double-digit % weight reduction on average? What are the things that you're stressing, and how do you explain to this patient the benefit of engaging in lifestyle intervention, especially when she says, well, it didn't really help in the past?
That's a great question, Jamie. And again, I think, as was said by everyone else, we got to come back to the patient and where she's at with this. And I think all of the medical therapies we have are, quote, approved as an adjunct therapy. So we don't want to ignore diet, exercise, and other behavioral modification. These are all very important. I think when we turn to our newer therapies that are so powerful, the question is, what should that lifestyle, change or recommendation be? In the past, it really focused more on caloric intake, caloric deficit, and increased physical activity. These drugs really do the caloric deficit for you. So, and we don't really know what the ideal diet. And I think there's a lot of interest in this. There's been some papers written on this, but there's really no firm data on what is the best diet. I think what we really need to provide for the patients is a discussion about a high quality diet. We want adequate protein. I think that's a big part of some of the muscle loss that is seen with weight loss is a reduction in protein. And so we want to make sure there's adequate protein. We want to make sure there's adequate hydration, and micronutrients, vitamins, etc. So the quality of the diet almost trumps the caloric content of the diet, in my opinion. And it's more similar to how we are having discussions with our patients who undergo metabolic bariatric surgery, and kind of the approach with them. I think we need better data. We need data to say, what is the adequate amount of protein, with these drugs? What is the exercise? Everyone says, kind of hand waves and says, oh yeah, we want to mitigate muscle loss, so you should do resistance exercise. We don't really have good studies to support those statements, but it makes sense. It's common sense. So again, I think on the physical activity side, more is better, but some is better than none. And so we want to promote as much as possible. Because again, we're talking about a long-term relationship here, a long-term treatment, and we don't know what the maintenance, and I'm sure we'll get to maintenance later in the discussion, but what will maintenance look like for this patient on medical therapy and lifestyle?
Great. So, Dr. Ryan, coming to you now with some of the more challenging questions here as our professor emerita. So what about the perimenopausal symptoms and this transition that she's going through at this phase in life. Again, I would say average percentage proportion of patients in our clinics, probably 75 to 80% female. So this is a common issue. And how do we navigate this in terms of helping her with these symptoms? Because one of her goals is energy, increased energy levels. And it feels to me like several of the symptoms that she's reporting are definitely having a negative impact on energy level. So should we be expecting that just losing weight is going to improve her energy, or do we need to do something else to address that? So help us out on the perimenopausal symptoms.
Yeah, Jamie. So let me sort of unpack this a little bit. You've obtained a PHQ-9 and an HAD questionnaire on this patient, and that PHQ-9 qualifies as having mild depression, and you need to follow up on that. And the HAD is moderate anxiety, and you need to follow up on that. So the patient is giving you a lot of signals of distress. And the way I look at this patient is that it's a pivotal point in her life. There are these huge hormonal changes that are occurring, and that is causing a lot of physiologic shifts. And the most important one, I think, to discuss today is the change in body composition that occurs across the menopause, where the body fat distribution in women who lose estrogen becomes more like men. And so we see greater visceral adiposity. And look, this patient has a blood pressure that is not normal, 134 over 82, an A1C that is not normal, 6%. She's got symptoms that are not normal. She's got a PHQ-9 and an HAD that are not normal. So I think this is, when I think about this patient, I think about what in the old days we would call metabolic syndrome, which now we're calling CKM syndrome. So we know that the origin, the root cause of chronic cardiovascular, kidney, and metabolic diseases is excess abnormal body fat. And this patient has excess body fat, and she's redistributing it to some abnormal depots, to that central depot. So I loved Ania's discussion about we need to treat the root cause. Those weren't her words. That was my interpretation of what she said. So yeah, I think many times this patient comes in the office and she might get metformin for the A1C of 6, or she might get a psychoactive medication or bupropion or something for the anxiety and depression. Or, maybe somebody would put her on a medication for hypertension. But no, we need to treat the root cause. And so I think that the very first step is having an in-depth conversation with this patient and talk to her about how these changes in her body are affecting the 4 pillars of health. And, we've got to address all of those. I think this patient is a great candidate for a medication that can really put her on the right track to not only losing weight, but improving all of those accompanying signs and symptoms.
Wonderful. Well, thank you for that great summation and a reminder about treating obesity first, which I think is one of the themes for Dr. Cornier's presidency this year in the Obesity Society. So I'm going to hand it back over to you. Thank you all for great insights and wonderful contributions here to the discussion.
Thank you, Jamie. And yes, treat obesity first, right? Not the last problem on your problem list. And actually it needs to make the problem list first and then be the first problem on the problem list. So we have some good questions from our attendees, and so we'll kind of pass them around. We'll start off with mechanism. So someone asked, is obesity a neurologic disease? Ania, you want to tackle that one? Because
Sure.
you're pointing at a neurometabolic disease. So tell us about that.
Yeah. So yes, obesity is a neurometabolic or a neuroendocrine disease. It's about how do hormones communicate with the brain to let us know how much energy or how much fat we're storing. And in the setting of obesity, within our obesogenic environment, our body stores extra energy or extra fat. And so we need to have treatments, and that's how we think anti-obesity medications work, that really target that underlying biology and target those mechanisms in the brain to help our brain and our bodies want to carry less energy or less fat. It's a really great question. I think that it's super important to share that with our patients and talk to them about it. It also really explains the manifestation that what our patients experience, which is, for example, if they're responding that they're having less food noise. Well, what is that? Food noise is a manifestation of that biology that their body is seeking to intake more food in order to maintain that increased adiposity. So when we treat that biology, that's why so many patients are seeing this mitigation or this lessening of that food noise. So I think it's super important to talk to our patients about it. It's a really great question. I don't know if others want to add.
Well, I think I'm sure that we could all answer that question in different ways, but let's try to tackle as many as we can in the amount of time that we have. So thank you, Ania. This one goes to Bob. So a recent letter in JAMA showed that over 98% of obesity based on BMI correctly identified excess body fat as determined by waist circumference and DEXA. I think we've all seen that paper. Given this data, why would we change our current approach to use waist circumference and/or DEXA, which is impractical?
Yeah, thanks, Mark. I did see that, and I welcome that letter. As I said in my presentation, the commission was the first step forward to move beyond BMI. So I read through that carefully, and what it says in general, it is a very useful population determinant for body fat as well as risk. But if you look at the population that was looked at, I think you get into the information that's needed where we have to do other anthropometric measurements. For example, they took individuals with a BMI 27 or more, and which excludes individuals may have a BMI 23 or 22, in which you may be misdiagnosing obesity just by BMI. They didn't look at that group. Second of all, they didn't look at anyone over age 60, which is the most vulnerable group that may have a low BMI and yet have obesity. And lastly, they look at the Asian population as a monolith. They just looked at Asian individuals where we know there are multiple different Asian subpopulations. So it's interesting that in the three groups where it's most important, that is a lower BMI, let's say 23 to 27, individuals who are older, greater than 60, and subpopulations by race and ethnicity, that they were not broken out. So I welcome the research letter, but it leaves a lot of questions unanswered.
That's a great answer. Yes, very interesting.
Well, thank you, Mark.
Jamy, back to your case. Should we be screening her for eating disorders, or was she? And what's your recommendations in that respect in general?
Yeah, so in general, what we tend to do in our practice is we have an assessment of a couple of different things. We do the Yale Food Addiction Scale, the version 2, because we see a lot of opportunity to identify treatable targets when we use that framework. It doesn't mean that we identify every patient as having food addiction, but we do find a lot of symptomology there. And there's now a new scale that will address or help identify what Dr. Jastreboff talked about in terms of food noise. So we're going to be incorporating that. And then we also do a binge eating disorder screen. And that helps us to, again, identify patients who have binge eating disorder, because we see that as being clinically separate from obesity, right? You can have obesity without binge eating, you can have binge eating without obesity, and you can certainly have both. And if you have both, then treating binge eating disorder in a separate vertical is often what you need to be able to do in order to see long-term success. Again, some of the newer therapies, we see a real decrease in binge eating frequency and tendency. And so there may be some interesting biology to really kind of further explore there. But for a lot of people, that also opens up the door to additional conversations around things like untreated ADHD, because impulsivity is a key link between binge eating disorder and ADHD, for example. So we find that lisdexamfetamine will actually solve a lot of issues for patients who have struggled in their personal life, their work life, and in their food life with regard to managing impulsivity. So I think, yes, in general, we screen all of our patients for binge eating, and we find that a significant percentage of people benefit from treatment of binge eating disorder.
Great. Thank you, Jamie. Donna, a couple of questions on semaglutide. First is, does it impact heart failure? And second, will it improve your patient's menopausal symptoms?
You know, we have no studies in menopause, but I think that is just such a ripe area for research. I hope there'll be some investigator-initiated studies that go after these GLP-1s and GLP-1 GIP medications to see if they see the impact on menopause, because you would think that by mediating what's going on physiologically with the adipose tissue in menopause, that you could maybe get some improvements in multiple symptoms. As for the heart failure, you know, this is so interesting to me because for many years we avoided weight loss in heart failure because of the so-called obesity paradox. And that is, you know, the individuals who, it was an observation that individuals who had heart failure and who lost weight had increased mortality. But, you know, that's not intentional weight loss. That's unintentional weight loss. And it's an adverse prognostic sign. So there's this growing incidence of heart failure with preserved ejection fraction. It's now overtaking heart failure with reduced ejection fraction as the number one cause of heart failure. And it is showing to be very responsive to treatment with weight loss. There's also improvement in heart failure with reduced ejection fraction with weight loss. And so we no longer have fears about that. So we do have evidence of, both with semaglutide and tirzepatide, of improvements with HFpEF. So improvements in how patients feel, that's the Kansas City Cardiomyopathy Questionnaire, how they function, the 6-minute walk test. And for tirzepatide, they also showed reduced hospitalizations. Very good.
Great. Thanks, Donna.
Yeah.
Lee, a couple of questions related to future treatment options. First is, how do you reconcile that a GIP agonist and a GIP antagonist can lead to weight loss?
I wish I could answer that question definitively. It is. This has been in the literature for more than 30 years now, where people have argued that agonism or antagonism of GIP causes obesity, and antagonism or agonism treats obesity. I think one of the ways of thinking about it is that when you activate any one of these receptors, you're activating a whole series of events. Some have raised the question that perhaps by chronically activating GIP, as tirzepatide does, the net result is to downregulate the receptor, so you're actually getting an antagonistic effect over time, and that it's been very difficult because you can't. It's, as I mentioned in the talk, this is a single peptide that has two activities, so you can't separate the activities, the GIP inside tirzepatide activity from the GLP-1 activity. So there's a lot to learn. The other possibility is that the opposite is true. That when you have an antibody to GIP, you upregulate the GIP natively, and that could lead to more activity, even though you're downregulating the activity initially. So we don't understand it. There is very great excitement about one of the drugs that I mentioned that has GIP antagonistic activity plus GLP-1. I think as we study those drugs and study the details of their biology, we'll learn a lot more.
Where do you see the role of the potential oral agents, incretin-based agents, in terms of how much weight loss compared to the injectables? What will be their potential role?
Well, we learned just this week that that orforglipron has weight loss effects that look to be similar to semaglutide, but it's an oral agent. It's an agent that doesn't require manipulation of food intake around the time of taking the pills. So I think that that's going to be an exciting development, assuming that the rest of the phase 3 program is as supportive as this first study appears to be. I think that one of the things that we can do with oral agents, in addition to not having to take an injection, is that we can be more flexible in the dosing. You can make pills of different size. You can get them approved. You can change. You can use partial pills depending upon how the drug is packaged. And that will allow us to do something that we really haven't been able to do in the past, which is to aim for the minimum effective dose of the drug for an individual patient rather than the maximum tolerated dose. The way the injectables have been developed is we go for the maximum tolerated dose. But that's not how we treat all other diseases, where we try to give the minimum amount of drug necessary to get to a target like a low LDL cholesterol or hemoglobin A1C or blood pressure. And so I think that the introduction of oral agents is going to have that opportunity for us.
Thank you, Lee. So Ania, we have one last question here. There's been a number of questions about maintenance, and one is, do you step down? What if they lost 20%, but they want to lose more? What are your goals when you're talking about longer term maintenance with the patients?
Yeah, it's a great question. And I saw some of those threads there in the questions. I think one, we have to look at each patient as an individual and that this is not one disease, right? So the reason why I say that is because there are patients who lose a certain amount of weight. And, one of the questions was asking, well, they lost a certain amount of weight, but they would like to lose more. Right. And so then you have to see, well, what is it about that patient, right? Where's their health? Where's their blood pressure? Where are they in terms of their health and weight goals? So really approaching each patient in that way and assessing, even if their initial goal was XYZ, is their next goal a different goal? Or did they surpass their goal? And are we doing more harm than good, right? So I think the first thing is really assessing where the patient is and what the goals are. In terms of, there's a lot of questions about what happens in terms of discontinuation of therapy or can therapy be spaced out? And again, we're learning about the different types of obesities and how patients respond. For the most part, on average, patients gain back weight when they stop the therapy that worked for them, right? That makes sense. And medicine doesn't work if you don't take it. And that's, what I was showing in the latter part of my talk, that it's not just that the weight is gained back, which it is, but that the blood pressure goes back up and that the lipids reverse and that the A1C goes up. So all of these other parameters in terms of health that are then reverting back to where they were. If we look at just the weight regain, there is variability. So some patients gain all of it back and then some. Some patients are better able to maintain, and we don't know the differences. Those patients are more rare, but we don't know what predicts those differences. So I think we really have to do more research there. But the thing to remember is, if we stop that medicine, it's not just the weight that reverts back. And I feel like we've been missing that. In terms of switching to other therapies, because there were questions about what if somebody loses coverage, we do have our older medications that we used for years that were effective as long as we use them in combination. So I think let's not forget about those older medications and really use them. And that's what we're doing to try and really help our patients. And there's many educational resources, including through the Obesity Society, that can help clinicians who maybe started out because of the highly effective medications now learn about how to use the older medications as well. So hopefully that's a comprehensive answer.
And briefly, Bob, do you have a comment on this topic?
It's actually a challenging dilemma because we talk about long-term treatment and yet we don't have those studies. And we still see patients who don't want to take a medication long-term for obesity, despite everything we've learned. And we tell them they still think it's their fault. So we have a lot of work to do in not only coming up with long-term strategies, emphasizing lifestyle management on top of this. I just want to add that not everyone regains weight. Ania was showing kind of average weight regains. But if you look at the categorical or individual responses, not everyone does regain weight. So we need to learn a lot more about those individuals.
Thank you.
Yeah, that's great. Well, I think we'll wrap it up. I think we've there are many more questions, but we could be here all day, and I'm sure people want to enjoy their Saturday with their families and such. So I want to thank the panel for taking the time for today. You know, a lot of great feedback from the attendees. So thank you all. And just wanted to, say this is an exciting time for the field of obesity, and there's still a lot of unanswered questions. So we still need more research, as I think we all have emphasized. We don't have all the answers, but certainly we're making strides, and it's, I think, very exciting. So with that, and I want to thank you all for taking the time today. We would love for you to join the Obesity Society. If you're not a member, please go to our website, obesity.org, to become a member. And you can also get more information and access, educational materials, the latest research, etc. Don't forget to complete any post-webinar surveys as well. And I want to thank also the team at the Obesity Society for all their efforts in organizing this event, and the organizers themselves. And thank you all for really a great session, tackling some very complicated topics. So with that, I will say so long, goodbye, adieu, guten Tag, all the different languages out there. And we will hopefully see you in Atlanta in early November for Obesity Week. Please join us there as well. And have a great day. Thank you.